nilianza kusikia mwili yangu kuna venye nimeanza kusikia ikiisha ni kama pasi za mwili, nasikia hiyo mwili haina nguvu.
Naenda Chuka hospital, saa zingine hata kulazwa hospitali tulikuwa tumelazwa huko, fanywa test, nikaambiwa ana. Mimi nilikuwa naona mtoto wangu mimi anaenda kukufa juu sasa mtoto alikuwa amekonda, mpikiwe akuli kitu.
Mama alikuja akaniambia bana, kijana wangu nenda hospitali ukaangalia. Lakini nilikuwa mbishi sana. Niliogopa kwa sababu ya stories za watu. Maana nilikuwa nimelose weight sana. Mpaka muda mwingine nilikuwa naogopa kutoka nje pia. Maana majirani, kuna majirani kadhaa walianza kunisema vibaya. So nilikuwa naingia tu kwa pharmacy, nachukua tembe na meza, mapainkiller hivyo. But hakuna mabadiliko ambayo niliona.
Nikaenda hivyo mpaka 2021, kwa zile block tunakaaga kuna kuaga na TB. Hivyo nikaanza kusikia kulingana na matibabu vyenye ya TB na vyenye mtu akishikwa na TB anasikiaga mwili.
Nilitibiwa TB, nikapona na niko sawa.
Daktari alienda akanipokelea poa, akaniambia saa kunatakikana mtoto apigwe x-ray ili tujue ni nini iko na shida.
Mimi nikaambiwa vile tuko na yeye na tunatumia mambo mingi sana na yeye, hata mimi nitakunywa dawa. Nikachukua tu ni vizuri juu afadhali ujizuie kuliko iende sana alafu uone afadhali ukianza mapema.
So following the successful implementation of TB ARC I, which ran between 2013 and 2018, CHS was again privileged to receive additional funding from USAID to implement the TB ARC II project.
This project is an example of a joint partnership to help identify issues to do with TB and to ensure that we can eradicate TB by 2030. The implementation of this project has been led by the National TB Program. Therefore, all the activities, all the vision, the goals and objectives are done and collaboratively implemented with the leadership of the National TB Program.
And the collaboration that we have is in the entire continuum of care when it comes to TB, from diagnosis, treatment and prevention, also at governance and management level, just being able to help us support the systems and make sure that they are functioning optimally to be able to deliver quality services to the patients that we serve.
We've worked with the National TB Program, the TB ARC II project, to implement a strategy of finding the missing TB cases. And this is active case finding strategy, where we ensure that all patients coming to the facility are screened for TB, and those who are symptomatic are tested and diagnosed with the TB and then linked to treatment.
We have also seen an improvement in the TB outcomes, that is the treatment success rate, which currently stands at 91%, and previously we were stuck at 88% and below.
Kenya prides itself as one of those countries that has been very upfront or very keen to ensure that we have a successful childhood TB program. With Kenya having been, for example, the first country globally to actually roll out the child-friendly TB medicines for treatment.
And we appreciate the support that was given by the TB ARC for training, coming up with the SOPs, coming up with a framework for implementation of stool testing in children in Kenya.
Tulienda kwa hospitali, mtoto alitibiwa bure, mandawa alipewa bure, hata chakula zenye wanapewa ya nutrition alipewa bure. After 1 month nikaona mtoto ameanzia kuwa na change. Saa hii ako sawa, anaendelea kugrow sawa. Sasa kwa mafikiri yangu nikaona ukweli mtoto ataishi.
Our cure rate has gone up. Our treatment success rate has gone up. Our diagnosis of childhood TB has gone up. Through the diagnosing of the TB, we were able to diagnose other comorbidities.
We also have support from TB ARC to support our children who come down with drug-resistant TB so that they are able to get their follow-up ECGs, their follow-up investigation that is required outside the Lancet that is being supported.
Because Lancet, which does for us the baseline tests, was contracted, and we've managed to be able to do all the baseline tests that are required for drug-resistant TB patients, which are also sent through courier. That also makes it easy and cheaper for the healthcare worker, cheaper for the patient.
If you remember that some of these samples in those facilities were staying even for 2 weeks before they go to the lab. But when we came in, we were able to do or to offer those services within a 24-hour cycle. So there's a whole process of training, there's a whole process of safety, and there's a whole process of packaging of the item.
Before the GeneXpert super user idea came, things were haphazard here and there. Mentorships were not being done. Routine supervisions that we normally undertake were never there. Commodity distribution and reporting was not aligned. So the super user came in and we were able to align the commodity requisition. We are also able to actually redistribute the commodity within the county and even go an extra mile to network with other colleagues outside the county whenever we have any commodity stockouts.
We have had a lot of support from TB ARC II, where we developed a service level agreement for the GeneXpert platform, where they were trained as trainers of trainers. And this model, we have been able to have the super users overseeing the GeneXpert platforms and the system.
This has been made possible courtesy of CHS supporting our super user to visit the 9 particular facilities on monthly basis to do the preventive maintenance, to do the OJT to healthcare workers, and also to solve any other occurrence that has occurred in those particular equipment which the routine worker is not able to sort it out.
In 2021, we reached out to various communities to identify various norms, behaviors, and issues related to TB health-seeking behavior, as well as adherence on TB services.
We came up with a number of interventions, and one major intervention was the development of social behavior change communication plan. We have increased our communication and awareness budget over a period of time. Key interventions was also the use of health journalists to document success stories, and also the engagement of content creators.
Where could he have gone?
Agatha kona TB. Na si ndio hii TB hapa? Hapana, tuberculosis.
We began the tuberculosis engagement in 2022, and it's been an exciting experience, honestly, because when we were beginning the engagement, I did not know the impact it was going to have on people in terms of how much educating people through comedy can change the lives of people, can change their perceptions.
I covered stigma, I covered symptoms, treatment, and basically the solutions, and also guys just going to for checkups, which was free, and people really loved it.
Kama huku jela, sometimes kuna mambo mingi. Isipokuwa ni TV kama hiyo ilikuja ikaongelelea vitu kama hizo, singeweza kugutuka haraka.
Matangazo yenye nilipata kwa redio ama kwa televisheni ilinipatia motisha. Ikanifanya kama ninatumia dawa, nilikuwa na ujasiri kwa nitapona.
Ugonjwa wa TB sio uchawi. Mtu yeyote yule.
The level of awareness has increased. Last year alone, we reached to over 15 million through radio and TV.
In the area of advocacy, TB ARC II has continued engaging various advocacy partners as well as community-based organizations that work on TB areas.
They're coming together to discuss
TB and the various objectives or various targets that we are looking into together is helping us now be able to have a common ground or page we can lead from.
Stop TB Partnership Kenya has been a sabawadi of TB ARC II. The establishment was because there was a gap in TB response in interventions that required advocacy. These mobilized former TB patients from all over the country to come together and form a coalition.
The network of TB champion has grown, and we now have champions, almost 450 that are spread across the country. And we've been going out there in the communities, in the places of worship, both mosques, churches, in market areas where border people are working, in schools, just creating awareness and telling the community what is TB and how TB is transmitted and how we can prevent TB in our community.
There was no coordination or module of work between the government and the public services.
CHS was able to expand private sector engagement for TB services, and this includes engaging corporates and various workplaces for TB services, expanding the engagement of private health facilities, and then of course expanding TB service provision within laboratories and private pharmacies and chemists.
After the CHS came in, we were basically well coordinated to ensure that we were well able to give the TB services to the best that we can.
By this, we've been done it by sensitizing the management team in these workplaces and the importance of their employees having knowledge on TB.
The program has helped us understand how to carry out the exercise. Either someone has tested positive for the TB, that person is referred to hospital. We are in much support to that patient because we understand it's a long period for recovery, like 6 months. They have to take drugs. We normally give them permissions to take drugs.
We've been able to really improve our outcomes. We've been able to improve the case finding for the private sector. We've been able to improve partnership, screening, sensitizations, health education. So my only request is that we be allowed to continue. We be allowed to continue with what we have begun so that we can actually see more positive impact and a more positive outcome for all our patients and also for the organization at home.
The health space is a very dynamic space. New policies, new modalities of diagnosis, treatment and prevention are being rolled out every now and then. And as a result, there is need for countries to continually update the current policies to ensure that the quality of services that patients are receiving is top-notch. We have also seen improvement in the policy making process because we are able to mobilize civil society and the infected communities to be part of this policy making process.
Another initiative that CHS was able to introduce through the TB ARC and TB ARC II projects is disseminating information and using data for decision making.
TB has basically guaranteed all stakeholders involved in TB control a direct route to data, and we have also ensured that at any one point our data speaks.
Again, TB ARC II has been supporting us to do monthly data reviews at our level, and this data helps us to do informed supportive supervision. So we are using data for decision making.
Initially, we were having problems with tools, but we thank CHS TB ARC II when they came on board and they took the initiative of printing us tools as a nation.
TB Data for Action was an initiative that happened after healthcare was devolved. It led to more TB coordinators being employed. They were able to do capacity building for TB coordinators other stakeholders and the national TB program officers for them to be able to use the local available data for decision making and during their support supervisions.
In 2022, CHS, in collaboration with the National TB Program through USAID funding, was able to roll out the Introducing New TB Tools project in Kenya.
As a country, we received a package of quite a number of tools. So the first one is the Truenat, which is a molecular diagnostic technology developed in India. It is more advanced than the normal microscopy that we use for testing TB.
Since its inception, we've been able to have more positive bacteriologically confirmed patients, since the Truenat is it's a faster way of diagnosis. And in our first 2 quarters of 2023, we're also able to get 11 cases through the Truenat and also get 2 more patients with the rifampicin resistance.
The second technology was IGRA, which stands for interferon gamma release assay.
Through this particular test, we've been able to identify individuals, particularly high-risk individuals, who may have TB infection and therefore who are eligible for TB preventive therapy.
So the other technology was digital chest X-ray with the computer-aided AI, which we are calling CAD for TB. And the technology was rolled out in 8 facilities within the country.
So we conduct targeted TB outreaches where we go to hotspots, areas with high concentration of TB. We organize for outreaches, we take services to the people, we screen them. Those who are symptomatic, we take sputum and network for GeneXpert. It has seen us comb those TB cases that are still not identified in the beaches, in the congregate setting, and other hotspots within the county.
So before we do any targeted community TB screening, we looked at our data and see basically which area, if we do targeted community TB screening or an enrich, we can get a yield.
By July this year, we had over 4,000 presumptive who are eligible to be sent to the lab as per the previous system. All these 4,000 would have gone to the lab if we didn't have a chest X-ray. But because of the chest X-ray, we screened them and only 329 were eligible to go to the lab. That is over 3,900 cartridges saved.
We have something we call TB-LIMS. TB-LIMS is a connectivity solution. So the moment you run your test, the results can now be sent automatically to the clinician in form of an SMS or an email, and then they can be able to initiate those particular patients on treatment.
We've seen different support coming from our partner, also the CHS Center for Health Solution, whereby they support the server hosting of these systems. We also see the monthly bundling, and also whenever we have new features within the system, we call our end users who come at one central point, and through our partner, they support the training and refresher programs for this system.
The other technology, basically not diagnostic, but also supportive system for treatment, is the DAT.
On digital adherence technology, we use medicine slips which are coded, which the patient will always send a code so that we can know if the patient took the drug on time, and it has enhanced better treatment to our patients since we have a good working relationship with our patients.
Madawa nilikuwa na meza, nilipata hizo dawa funkaambiwa muda ambao nitakuwa na meza. Sasa mimi kama mimi nilikuwa na hizo dawa na zimeza usiku saa 1:30. Baada ya kumeza kuna namba nilikuwa natuma pale. Hiyo namba nilikuwa natoka ile box ya dawa. Baada ya kutoa zile dawa ilikuwa nyuma ya dawa. Nilikuwa naikopi pale afu ndo naituma kama SMS.
Overall impact, I will say first for the patients themselves, they have created ownership because they've been getting the reminder message, so they are able to come to the facility on time, and even our treatment success rate have really improved. In 2021 we were at a TSR of 89, and in 2022 we are at 92%, And as we speak, the ones who have been enrolled in this year, that is January to March, they have already completed treatment and have a TSR of 94%.
So the other thing that was also being supported through this particular initiative is TB preventive therapy, TPT, in which the patients that were testing positive for IGRA were being initiated on this particular treatment.
TB preventive therapy, it's a new strategy. We encourage the community health promoters to go to the households. They bring us the contact of the index patient, and once they bring them on board, we screen them further just to make sure that they do not have signs and symptoms of TB, and if they are asymptomatic, we start them on TB preventive therapy.
Hata wakati alikuja akaniambia amepimwa na akaambiwa kuna tuberculosis, nilimwambia hakuna shida, inashikaga kila mtu. Daktari akamuuliza nani mnakaa na yeye, akamwambia mimi niko karibu sana na yeye. Huyo daktari akamwambia tukuje na yeye. Mimi nikaambiwa vile tuko na yeye na tunatumia mambo mingi sana na yeye, hata mimi nitakunywa dawa. Mimi nilipewa dawa na nikaambiwa sitanunua, lakini vile tuliambiwa hapa hakuna kitu tutakuwa tukinunua, hata kadi ya siku hiyo sikununua.
Prior to the TB ARC II project, through the funding and support from the USAID, CHS received grant to develop an accounting and administrative systems that would be able to first monitor, capture our expenses in a manner that the leadership can get accurate and reliable data in how finances are being used for the project. The fleet management system has contributed heavily in providing efficient movement of both human resources who are employed to serve the project, and also to a greater extent distribution of registers wherever our employees go out in the field to carry out TB ARC activities.
Basically, my work is to transport regional officer, especially during support supervision from one region to another, transporting county staffs, especially the CTLCs and the LCTLC, from one facility to another during supervision.
The kind of support we've had from TB ARC II is the cashless reimbursement. So this support has been able to help us in terms of lunches, transport, and at times, because these islands are so far, so night outs at some point has been able to assist us in reaching these areas.
TB ARC II has been aligned in its work to the global NTB strategy targets. Kenya as a country actually achieved and surpassed the TB incidence target, because we achieved 32% reduction in TB incident from the baseline of 2015, which actually surpassed the global target of 20%, which is a significant milestone for Kenya. Kenya also surpassed the target for reduction in TB deaths, achieving 44% reduction against a target of 35%. And overall, Kenya was transitioned out of the list of countries that were high burden for drug-resistant TB. To USAID as a donor, to the Ministry of Health and the National TB Program, and all the partners, I think we've set a strong foundation, a really firm foundation for the TB response in Kenya. But there's a lot more to be done. We still have certain challenges that need to be surmounted, and we can only surmount these challenges by working together, collaboratively.
We have to expand our ability to find this TB, and that would mean that we need to increase access to digital x-rays. We need to increase access to molecular WHO recommended rapid diagnostic tests for TB, and also train healthcare workers to be able to use this equipment and to be able to detect more TB where it is found, both at the facility level and also at the community level.
So we appreciate the work that partners are doing out there, and we are also calling on to other partners. Now is the time, because we are in the fight to end TB, and we cannot end this TB by 2030 if we don't work together. Tumeshukuru kabisa juu
hatungeweza, kama ni sisi hatungeweza. Na tuseme hao madaktari mumeweka kila mahali, hao watu wako na ujuzi na wako na roho ya utu.
Hata wenye wanasapoti tupate hizo dawa waambie tumeshukuru, na tumeshukuru juu kama ni kununua tungekuwa tunateseka kununua.
Mimi naweza ambia asanteni sana, mmeokoa maisha yangu na mmeokoa pia maisha ya watu wengine. Maana wakati nilikuja huku pia nipate watu wengine pia wanaugua. Umetokoa sana, hatujalipa kitu chochote, yaani mbarikiwe tu sana.
TB is real, TB is curable, and TB is treatable. So let us come out there, go for TB screening, and once you are diagnosed with TB, adhere to treatment to the full course, because TB is treatable. So mulika TB, maliza TB.